27-year-old female patient Brandy presents to the emergency unit with sudden onset chest pain and shortness of breath. She doesn't have any fever or a cough. She is a mother of 2 kids, and for about 3 years, she has been on oral contraceptives. In her pregnancies, she has had similar episodes of chest pain and shortness of breath, but she cannot remember what the doctor said the problem was. Could this be a potentially life-threatening condition? Hi, you are watching ED Files, and I am Dr. Thabo Mafa. Shortness of breath could be a symptom of heart or even lung problems, amongst other things. It is one of the most common presentations we would see in an emergency unit. When pulmonary embolism is a main cause for this symptom, it could have devastating outcomes if not treated promptly. And the question is, what is pulmonary embolism? Pulmonary embolism is an occlusion or a blockage of a vessel in a lung by a clot. And this clot in most cases would come from the lower extremities of your body, like in your legs. What could be the risk factors for this condition called pulmonary embolism? If a patient is not mobilizing enough, for instance, for someone who works in an office from 8 to 4 o'clock without moving around, that could put them at risk of having clots in their legs that can eventually shoot into the lungs. Use of oral contraceptives is also one of the risk factors. And also, pregnancy can put a woman at risk of having clots that can easily shoot into the lungs. And not forgetting deep vein thrombosis. Deep vein thrombosis is clots that are in your bigger vessels, in your lower extremities, and these vessels can sometimes carry clots that can be shot straight into your lungs. Brandy presented to the emergency unit with sudden onset shortness of breath and chest pain. However, in most cases, a patient with pulmonary embolism may present with atypical symptoms or non-classical symptoms. And these symptoms would be like a patient who collapses at home or has got a seizure at home or a sudden onset fast heart rate, whereas the classical symptoms would be shortness of breath and also chest pain. What are the findings you could possibly have when you examine a patient with pulmonary embolism? Brandy presented with a fast breathing rate of more than 20 breaths per minute. Her heart rate was more than 100 beats per minute. She was diaphoretic, meaning that her skin was cold and clammy, and she was sweating a lot. She had swelling of her legs, especially more around the calf area, and it was tender to palpation. She had loud heart sounds and also additional or extra heart sounds, which we call them a gallop rhythm. She was cyanotic. The tips of her fingers and also the lips were blue in color. Her blood pressure was very low. She was hypotensive and she was in shock. Now the question is, what are the possible complications of pulmonary embolism? Remember, pulmonary embolism is a clot in a vessel that goes into the lung. A patient could have an abnormal heart rhythm from that, or they can go into a cardiac arrest, meaning that the heart could stop beating. They can have a phenomenon which we regard as a right to left intracardiac shunt, and that simply is a build-up of pressures within the vessels that would eventually increase the pressures within the right side of your heart. And in trying to compensate for those high pressures, your heart will start moving blood from the right side of itself, the right chambers, to the left, in trying to equal things out. But that could result in the muscles being weakened and heart failure. You can have lung infection. This means there will be compromised blood circulation to the lung tissue. Or you can have a buildup of fluids within the pleural space, which we refer to as pleural effusion. Brandy presented to the emergency unit with sudden onset chest pain and shortness of breath. And the question is, what could be the possibilities, or what are the differential diagnoses? A patient who comes in, just like Brandy did, we could sometimes think that this is merely just a heart attack. Or we could think a patient is just having an anxiety disorder. Or a patient who's been brought in by the paramedics, unconscious. Sometimes we can look at that in isolation and say, oh no, they just fainted. Or a patient could be having pleurisy, which is inflammation of the linings of your lungs. Or sometimes we could have a look at the ECG and we just say, no, they're just having an abnormal heart rhythm, without looking deep into it, what is the main cause for it. The reason I'm mentioning this is, these are differential diagnoses. However, they can also be misleading to a clinician, especially if they are being looked at in isolation, not digging deeper into what the problem is. How do we then investigate a patient like Brandy, who comes in with a chest pain and shortness of breath, which were of sudden onset? We did bloods. We did a D-dimer test. And this would tell you about how thick is the blood, or what is the likelihood that a patient could be having a clot somewhere in the body. We did a white cell count, which is the infection marker, looking for any evidence of infection. We also did a CRP to check for inflammation. We did a troponin T, which is a marker that we look at closely to exclude a heart attack. And we also did a blood gas. On the blood gas, you look at your oxygen levels, amongst other things. And we also did some imaging studies, like chest x-rays, to look if there is any evidence of chest infection that could result in shortness of breath. And also the gold standard investigation that you would do in a patient whom you suspect they could be having pulmonary embolism is a CTPA, a CT scan of the chest that looks at the vessels. We also did an ECG to check if there's any abnormality in the ST segments, those waves that you see on an ECG, if there is an abnormality. How do you then treat a patient with pulmonary embolism? What is the treatment? So the idea mainly revolves around stopping formation of new clots and also breaking down the clots. Basically, that is the main idea around treatment. So we do what we call thrombolysis. And this is considered when you see that there's a high index of suspicion of a patient having pulmonary embolism. And in most cases, we do it for patients who are hypotensive, low blood pressures. Their systolic blood pressures should be less than 90 millimeters of mercury in most cases. And these patients should not be having a bleeding risk. The other mode of treatment for these patients is what we call anticoagulants, such as Xarelto. Anticoagulants break down the clot. And the studies have shown that Xarelto is more preferred recently than warfarin. Reason being that when you use it, the chances of recurrence of pulmonary embolism and also deep vein thrombosis get lesser. How do we then manage a patient with pulmonary embolism? An unfractionated heparin, like Clexane, and preferably this has to be done within the first 24 hours. But if a patient is considered to be unstable with very low blood pressures of less than 90 millimeters of mercury, and that is a systolic blood pressure, we would give them a thrombolytic to break down the clot as soon as possible. And further on, we would give them oral anticoagulants like Xarelto. And did you know that recently Xarelto has been given more preference over warfarin? Reason being that it reduces the chances of recurrence of clots in your lungs and also in your legs. And the other mode of treatment of pulmonary embolism is surgical. They do what we call thrombolectomy, whereby a clot is manually removed from where it is blocking a vessel. And perhaps you're asking yourself, when taking this medication for deep vein thrombosis like Xarelto, how long should you take it for? If a patient has got no other risk factors like chronic diseases, or there's no history of recurrence, in most cases, you can treat them for about 3 months. However, most patients would receive patients for a period of about 6 months. These patients would also need supportive care in a form of prescribing compression stockings for them. And these stockings would help ensure that there's no formation of new clots in the calf area. And the recommendation is that these clots should be at a pressure of about 30 to 40 millimeters of mercury and should be worn for about 2 years. Secondly, we must also encourage these patients to mobilize more frequently. What were the outcomes that we had about Brandy regarding her condition? Remember, she presented with shortness of breath, which was of sudden onset, and also chest pain. She had risk factors. She was using oral contraceptives for about 3 years. And also, there is history of recurrence of the same symptoms, which we would assume that most likely it could have been pulmonary embolism, even though she doesn't remember everything. She had symptoms or signs that were suggestive of someone who's got something wrong within the lung or the vessels that go into the lungs. She had a heart rate which was quite fast. Her breathing rate was also fast, of about more than 20 breaths per minute. And she had oxygen saturation which was less than 90% on room air. And on the investigations, we've done the white cell count, CRP, a D-dimer. The infection markers and the inflammatory markers were both within normal limits. However, her D-dimer, which is a marker that would tell you of probability of having a clot in your chest or in your legs or anywhere in your body, it was very high. And we also did chest x-rays. A chest x-ray was normal. There were no signs of chest infection. And the gold standard of investigation, which is the CTPA, CT chest of the lungs, which would look at the vessels as well, indicated that definitely Brandy has got a clot within the vessels that supply your lung. And furthermore, Brandy was stabilized in the emergency unit. However, she had low blood pressures. Her systolic blood pressure was less than 90 millimeters of mercury, so she was considered unstable. So we gave her a thrombolytic to break down the clot as soon as possible. There were signs of improvement after doing that. She was admitted to hospital and taken to ICU, where she made a speedy recovery. In conclusion, pulmonary embolism does not always present with typical or classical symptoms, and it can be misdiagnosed or even missed altogether. A clinician would need to have a high index of suspicion, looking at the presenting complaint, physical examination on the patient, and also the investigations, in order for them to be able to get to the diagnosis. It is a potentially life-threatening condition, and if the patient is not treated promptly or investigated on time. So early recognition of the signs and symptoms of this condition, pulmonary embolism, and commencement of treatment as soon as possible can save a patient's life. And thank you for watching.